the polypodal structure here, also in the left nasal cavity. On CT scan nose and paranasal sinuses, in coronal, axial, and the sagittal view, we see the inhomogeneous intensity lesion found in the ethmoid region and the maxillary regions, and also find the osteogenic chains in the ethmoid region. CT scan report reveals bilateral sinonasal polyposis of starting osteometal complex and septum deviated to right side with septal spine. So our final diagnosis is bilateral nasal polyposis with deviated nasal septum right. Our plan is functional endoscopic sinus surgery under general anesthesia, demonstrated by our foreign faculty, Gautam Shankar Medikheri sir. Thank you.
So now I will request Dr. Gaurav Shankar Medikheri to demonstrate the CT scan of.
Yeah, hi, thank you so much for having me here. First of all, big thanks to Dr. Zakaria Sarkar sir and Dr. Alam Chaudhary sir for inviting me over. Am I audible to the audience?
Yes,
Hello?
sir.
Yes, please.
Okay.
We can hear. Yes.
Yeah. So thank you so much for inviting me over. And the first case that we are doing is a case of inflammatory sinus disease. So this is the scan that we have here. Unfortunately, what we have here is actually a soft tissue cut. So you can actually see that the bone is, we don't have a lot of detail in the bone. So that makes it a little challenging, because then you will assume that these are all osteotic changes, which may as well be. So the first cut that we're seeing here is going through the frontal sinus. We can see the eyes. This is the premaxillary segment of maxilla, which we are seeing here. Posteriorly, as we go, we can actually see the frontal sinuses on both sides, the frontonasal beak. We are not seeing an opening in the frontal sinus yet. So in the next cut, and we can start to see some of the bony septum. That is the maxillary crest, what it assumes to be. That is the ascending process of maxilla. And as we go posteriorly, you can actually start to see the appearance of the middle turbinate here. Okay. Actually, I'm not going to take a lot of time on the CT scan, because we've had a wonderful lecture on CT scan already. So what I'll probably do is just discuss with you what are the key findings that we have, and what are the things that we should probably expect. So this is going to be a little challenging case, because there is probably, especially in the left ethmoid, we have a lot of osteotic bone along the skull base also. If you see this sagittal section, you'll see along the frontal sinus, there is significant amount of osteotic bone that we see here. And we might have to drill this bone down in order to have a very good opening of the frontal sinus. You can see a prominent frontonasal beak as well, here and here. And there is a osteotic focus which is actually blocking the frontal sinus ostium. That is one of the challenges that we have. The second challenge that we're going to have is, as you go posteriorly in the posterior ethmoidal group of cells, you can see that the cells are actually very small. The bone is actually quite thick and osteotic. So again here, in order to open up this whole space, and the sphenoid sinus is also again quite small, dominant only on the right side. Left side sphenoid sinus is actually very small, or probably even non-existent, we can say. The other issue is that you have on the right side, you just compare the right side maxillary sinus. When you compare it to the left side, you can see that the is much better on the left side when compared to the right side. So this looks to me like a hypoplastic maxilla on the right side. So what we need to do is, you have to stay low down. Because if you open this orbit higher, you open this sinus high up, you are probably going to enter into the orbit. Okay, so you have to be careful on the right side maxilla. The pneumatization is not much. Why? Because there is a septal deviation which is towards the right, and that has probably made it difficult for the sinus to get pneumatized, because there has been restricted air entry. Okay, so this looks like there has been an issue since childhood actually, but it's probably gotten worse in the last 5 years, because the degree of inflammation is very significant in this case. So I'm going to love demonstrating this case, because this is going to be a very realistic case for you. What happens is, whenever we do a demo, we choose a very nice case with very little inflammation, and we demonstrate a beautiful surgery. But this one, we are going to have quite a lot of bleeding in this case, actually, because of the degree of inflammation. It's got nothing to do with the blood pressure, it's got nothing to do with the surgeon also, but it's got to do with the degree of inflammation in the patient's sinus itself. And that inflammation is going to give us bleeding. But what you'll observe is, after we drill out or after we remove all this osteotic bone and clear out all the sinuses, you'll see that the bleeding will actually stop. Okay, this is one thing that you will have to pay attention to. So, without any further ado, probably we can go to the case now, because I like I said before, I don't want to waste too much time discussing scan, because that's already been discussed by the previous speaker. So I just wanted to discuss the pathological part of this patient. You have some sterilium? That's okay. Yeah.
Hello.
Yeah, you have any queries? I'm happy to answer them.
Yes. So one of my question is there is osteotic changes, also
Yeah.
the massive inflammation.
Yes.
What is the preoperative preparation of this patient, particularly to reduce the bleeding, perioperative bleeding?
Yeah, so you can give the patient steroids preoperatively, oral steroids, which usually should last for about 3 weeks.
3 weeks. 3 weeks. So
3 weeks prior to surgery, you can give steroids. It all depends on your experience. Like, if you are happy to pull off this case, in spite of the bleeding, you are happy to open up all the cells, then you will not really have such a big problem. You can also use some intraoperative techniques. It's actually 7.5, so next case we'll use 7. That's okay. So next case we'll use 7. This is very tight. You can also use some intraoperative techniques to sort of reduce the amount of bleeding that we have.
What is that?
Sorry?
What is that intraoperative technique?
So we can actually raise the head end of the patient by 15 degrees. So that actually allows us to prevent venous congestion in the upper airway. Can we have, I don't use this, I'll have a straight blade strip. Yeah. You can keep this, that's it, I won't use it actually. The second one is, we are going to use Merocel, which is soaked in adrenaline and normal saline in a ratio of 1:10. So here you can see that they have done a wonderful preoperative preparation. You can see that the polyps are almost non-existent here, especially after decongestion. If the patient had not been prepared, I would usually take a biopsy of this polyp. The reason being that you want to identify what is the inflammatory load in this patient. Can I have a septal elevator, please? So you can see that this patient's turbinate is a little prominent. So what I would like to do before we proceed is, I'm going to go into the inferior meatus high up. I'm just going to infracture this turbinate to sort of create some space here and then outfracture it. So when we do this, we usually prefer to use the whole shaft of the instrument to sort of outfracture the turbinate. Okay. So now you have a lot more space. So this allows for blood suction, please. So this will allow for the blood to actually trickle into the nasopharynx. So you can see there is a lot of thick mucus. So this is basically mucus which is supersaturated. What happens in these cases is that patient will have mucus which is actually supersaturated with inflammatory cells. So because of that, the mucus is usually very thick in consistency. This thick mucus, combined with the fact that patient has had a long-standing history of inflammatory sinus disease, which makes the mucociliary movement almost non-existent in these patients, that causes sinus stasis. And this thick mucus will actually trap all the allergens that this patient has. So there are some markers here which are telling me that this patient has got history of allergic rhinitis. The most important marker that you need to see, before I talk about the marker, let me just orientate you. I'm in the left nasal cavity of the patient. Can I get some feedback from the audience in the sense that, can you see what I'm trying to show you, the endoscopic image here?
Yes, sir.
Yeah, so this is the left nasal cavity, this is the nasal septum, this is the inferior turbinate, this is the middle turbinate. Here we are probably seeing the uncinate here and the bulla ethmodalis. So if you just trace, this is a small polyp. If you trace the middle turbinate backwards, you can see there is so much edema in the middle turbinate. Can you see this whitish stuff here? That is not mucus. This is actually edema of the middle turbinate. So when you find middle turbinate is edematous, right? This is called as a diffuse edema of the middle turbinate. If you find small spots like this, which are not continuous like this, right? If you have intervening islands of normal tissue like this, okay, then that is called as focal edema of the middle turbinate. That is actually grade 1. Okay, this is probably a grade 3 edema of the middle turbinate. Okay, so what is the significance of finding this edema is that when you see edema of the middle turbinate, the diagnosis goes in favor of allergic rhinosinusitis. Okay, so if you do an Ig level for this patient, or if you do an absolute eosinophil count for this patient, is going to be very much on the higher side. And when you find this sort of edema of the middle turbinate, what should you do? You should do a skin prick test for this patient. That is what is very, very important to sort of figure out. This is one of the most consistent endoscopic findings that you have to look for, whether or not that this patient could have an allergic etiology. Why is this important? Again, because even if you operate on this patient, you are not going to be able to change the DNA of this patient. Okay, you have to understand that. Allergy is a genetic disorder. So there are two chromosomes which are normally involved in allergy, number 5 and number 11. Okay, now there is a mutation in both of these genes, and that is the reason why whenever this patient comes in contact with dust, fume, smoke, pollen or whatever it is, he will develop an allergic reaction. And the fact that he has so much osteitis in the bones is proof that this patient has got an allergic etiology. Okay, so we need to address this allergy in the later days also, after the surgery as well. If you don't do that, what is going to happen? His disease is going to come back and the surgery will get a bad name. So you have to counsel this patient beforehand, before you take him up for surgery, that you have an allergic problem. What is the surgery going to do for you? Surgery is going to allow you to rinse your sinus with steroid, because he's had this disease for a very long time. So he's in the phase 2 of the inflammatory reaction now. In phase 1, which is driven by histamine, your antihistamines will work. But in phase 2, okay, where we have predominantly a lot of inflammatory markers which are released, like leukotrienes, interleukin 3, 11, 5. So when these markers are released, antihistamines are not going to work here. What is going to work is steroids. So that is the reason why when the doctors here have given him steroids, you can see that he must have had a significant improvement in his problems also. So when we do surgery now, it is only to open up the sinus, allow the mucus to drain, reduce the inflammatory burden. What are you meaning by reducing inflammatory burden? You are taking this reaction from a Th2 predominant type of reaction to a Th1 predominant reaction, and you are reducing the amount of inflammatory tissue in the sinus. And the most important reason for doing surgery would be to allow the patient to wash with steroid. So when he washes with steroid, you are doing two things. One, whatever dust, pollen, fume, smoke is there inside, that gets washed out. So you are not allowing that to sit inside and create a reaction. And the second thing that does is that the steroid which is contained inside the wash, without giving him any side effects, it will actually reduce the inflammation. These are the two important things that you are doing. Let us say your argument might be, why don't I just keep him on oral steroids? Let us say he doesn't want to get surgery done. I can keep him on oral steroids if it's a young patient, if he's not diabetic or anything. Why should I not do that? Yes, you can do that. But the problem is, you're not removing the trigger here. So you give steroid, it will work for 8 hours. But from the 9th hour, the dust which is sitting inside his sinus will get reactivated. So what are you achieving? It becomes a vicious cycle. So the patient is bound to take more and more and more steroids. Mind you, why steroids? Why not antihistamines? Because patient is already having this issue for at least 5 years. That means that he is already in phase 2 of the reaction. So antihistamines will not help him much. So it is our job to explain this to the patient and convince them that he requires a good surgery, that is mainly to allow him to wash with steroids. Okay? So that being the pathophysiology of the problem, now we are just going to proceed with the surgery. If you have any doubts, please feel free to ask me. Debrider is working.
Is it the type 1 inflammation or type 2 inflammation?
This is a type. This is a Th2 inflammatory predominant.
Type 2 inflammation who is really reacts with the steroid.
Suction. So there is no type 1 or type 2. This is phase 1 or phase 2. Phase 1 is where it is driven by by histamine, which lasts for a couple of minutes to couple of hours. After that, it comes into phase 2, where you have predominantly interleukin 3, 5, 11 and leukotrienes, which are playing an important part. Can we have the AC on? See, when I'm inside, the suction is not working.
Hello, Dr. Gaurov, can you hear me?
Yeah.
Yes, please, can you show the audience the unsynaptic process and before you debride? Before you debride, you just give us a view of the unsynaptic process, where the unsynaptic process is attached.
Absolutely.
And
So
yes,
here,
please.
actually, see, the unsynaptic process is continuous with the lateral wall of the nose. Can you see this?
How our juniors can identify the unsynaptic in operative field?
Yeah.
Just you give some
so see,
tips.
this is the unsynaptic process here, but you are finding a gap here. Can you see this? So whatever is lateral to this gap here is actually the unsynaptic process, and this is the mobile part. You can see that this is moving, but if I try to move this segment here, this is not moving. Okay, so this is actually the lacrimal bone. Unsynaptic process is attached to that here. Can you see that?
Yes.
Okay, so this is the unsynaptic process, but unfortunately because of fibrosis, long-standing inflammatory disease, superiorly the unsynaptic process has become polypoid. Can you see that?
Right.
Yeah, and it has also attached to the middle turbinate here. Can you see?
Yes. Some part of the
Unsynaptic is attached to the middle turbinate as well.
Superiorly.
Yes. So that is because of the sinus inflammatory disease that he's had for such a long time. And here also you can see this is bulla ethmoidalis below here, this part. The unsynaptic is attached to that also. Okay.
Yeah.
So the unsynaptic has got 3 parts.
Yes.
So this is the upper part. So this is called as the vertical part of the unsynaptic process. Okay. The second part is called the intermediate part. So from the vertical part, that is usually at the lower margin of the middle turbinate,
right.
it turns down and becomes the intermediate segment. So this is the intermediate segment. And the third part, which runs along the middle turbinate, is actually called as the horizontal part.
The third part.
Yeah. So normally when we do an uncinectomy, we should do it at the junction between this intermediate segment and the horizontal segment. So somewhere here, we should do the uncinectomy actually. Okay. Debrider is working now? Okay. So what I would like to do is, I'm just going to debride all of these polyps which we have. Okay. I'm not going to remove any of the bone. So I have been advised that I should take some time to discuss the basic stuff, because a lot of youngsters would want to do more and more basic work. So see what, can I have a ball pro? So what have I done now? You can see very clearly that I have actually released the unsynaptic process from the bulla. Can you see this gap which has been created? So there was an attachment here, agreed?
Yeah.
So that gap I have now created by just removing the polyp. Okay. So now, see, you can now very clearly say this is the intermediate segment
Of the unsynaptic.
Yeah, there looks like there is an anterior fontanella here. Can you see this? Okay, this is an anterior fontanella here. This is the unsynaptic process, intermediate segment, and this is the horizontal. Now give me a backbiter. Now I'll show you why we should open exactly at this junction, that is between the intermediate and the horizontal segment. Why we should open here? That is because the ethmoidal infundibulum actually opens into this segment. Okay. So without even doing anything, I'll just show you. Give me a J curate, please. The minute you open into this area, you have a straight J curate. Or give me a ball probe. Ball probe, yeah. Just hold this sister, please. So see, now without doing anything, just if I push this horizontal segment down, you will be able to see that we are inside the maxillary sinus. See, this is the bone of the unsynaptic horizontal segment. Okay, this is very hard. Normally, unsynaptic will not be this hard. Okay, why it is hard? It is because of the osteotic bone. This is very osteotic actually. Upturn blade. So it is our job. So how do you know that the previous surgeon has done a good job or not? If you just see whether they have done a good uncinectomy or not, you can actually tell whether the previous surgeon has done a complete job or not, just by looking at how well they have done the uncinectomy. Why? Because that is the most basic step.
Uncinectomy is the prime.
Yeah.
an important step of doing
So
the further surgery.
what I want you to observe is I did not pull any of the mucosa out.
Nah,
Okay, that is
I'm
very, very
leaving it.
important. Try to preserve as much mucosa as you can. Can you see I am already inside the maxillary? See that?
Yes.
So that is the opening of the maxillary sinus into the ethmoidal infundibulum. See that?
Yeah.
You can see there is a lot of mucus there. See this?
Yeah.
So that is the reason why. See, this is the horizontal part. I have not removed the bone. I have preserved it just to show you that this is the horizontal. See, this is the horizontal part. This is the vertical part. In between, I have removed the intermediate part. And where did I come? I came straight away into the maxillary sinus. Can you appreciate that?
Thank you.
Yeah.
Well,
Yeah. So can I have a straight blade split, please? So now what I'm going to do is, one second. Let us first.
चॉकलेट नहीं नहीं चॉकलेट
So see now what I'm going to do is I'm going to remove this bone that is the horizontal part of the uncinate process. Okay. We're just going to try to tease this bone out. See that? Only the bone. Okay. And next we will just use a debrider. Go in and observe how the blade is actually closed when I go in so that I don't create any injury anywhere. Okay, and I'm going to remove the whole of the uncinate process. Vertical segment, horizontal segment, intermediate segment. All three segments I'm going to remove.
Dr. Shaurav. Hello. Can you-
Gaurav. Yeah.
Gaurav.
Yeah.
Can you hear me?
Yes, sir.
Here is a different level of students and resident or junior doctors here.
Yes, sir.
And when you do the debrider, use debrider in uncinate,
Yes,
doing
sir.
the uncinectomy,
Yes, sir.
is there any advice or different tips?
Yeah.
How can he do it
Backbiter?
without injuring the lamina papulosa?
Absolutely, sir. So that's a very important
so
point
if you,
what you
if,
mentioned.
you, if you give some tips here,
Yeah.
how they
Yeah.
hold the instrument, how they do it, it will be helpful for my residents.
Absolutely. So just before I did the debridement, if you observed, I actually fractured the upper part of the uncinate. Could you appreciate that? Before I did the debridement, I actually fractured the upper part of the uncinate. So what that I did is along the lateral wall of nose, I actually went. You have to stick close to the lateral wall of nose and fracture it. Okay. So when you do that, then you don't need to actually give me a mirror. Just keep 2-3 mirrors here. So you don't need to actually touch the lateral wall or touch the tissue. If you just allow the tissue to come into the debrider and get sucked and then debride it, then you will not have a problem. The other thing that you need to do is you have to appreciate on the scan whether or not, I like a straight suction. Curved suction is only when we use a 70 degree scope. So I'd like for you to appreciate on the scan whether the uncinate is actually medialized, intermediate, or if it is lateralized. So if you have a lateralized uncinate process, then you need to be very careful. Preferably if you are a beginner, don't use a debrider to remove a lateralized uncinate process. If it's a medialized uncinate process, then you can just use a sickle knife and go antegrade. So I just want to explain what is antegrade and what is retrograde uncinectomy, okay? Antegrade uncinectomy is when you go from front to back. That is, you open the uncinate process using a sickle knife from here. Retrograde is when you use a backbiter to open into the uncinate. That is, you identify a gap between the bulla ethmoidalis and the uncinate process, and then you go into that space, which is actually the ethmoidal infundibulum, and you break the bone backwards. So that is called as retrograde uncinectomy. If you have a lateralized uncinate, then it's always preferable to do a retrograde uncinectomy because it's much safer. Whereas if you have a medialized uncinate process, then it is more convenient to do a antegrade uncinectomy because retrograde will be very tough because you might injure the middle turbinate in such a case. Okay. What I want you to observe is one of the tactics that I use when I am doing surgery to reduce bleeding. If you observe, I am not going to suck on mucosa which is already opened up. Okay. On this mucosa, if you suction, there is nothing that is going to happen because the blood vessels are not exposed. So the capillary pressure will be the same. But when mucosa is open, like in this case, if you keep suctioning here, if you observe, it will keep bleeding more. See that? Because you are actually increasing the capillary pressure by the negative suction. So what do you do instead is you use a Merocell piece to actually suction on it so that you don't injure the mucosa with your suction. Now if you just see after removing this Merocell, what is going to happen is you will see that the field will be much less vascular. Okay. So this is one of the tactics that I actually use. You
Very
have
good.
40 rad blade. So now you can appreciate that the uncinate is out. There is a little bit uncinate intermediate segment backbiter you have, which I might take it out with a backbiter. So the other important point that you need to remember is the relationship of the nasolacrimal duct with the uncinate. Okay? Give me a wash, please. Yeah, just keep wash ready. Where's the suction? Let the suction be towards me. Okay? Yeah. 1 second. Can you just take that? Yeah, please wash. It didn't come out. Yeah, okay. Now wash, please. So whenever you feel that the field is a little bloody or blood stained, just take a wash. What this wash will do is it will clear off all this blood clot and debris. And remember, when you are suctioning in the nose or the nasal cavity like what we are doing now, suction from posterior to anterior. Don't suction like this. If you try to suction from here, you will actually injure the mucosa. Whereas if you come backwards, see this? This gentle motion will not make any injury to the mucosa. Okay, so that way you can actually reduce the blood in your field. Already you are expecting that this is going to bleed. So you should not actually create more number of bleeding points here. Okay, that is one of the important things to remember. Now we are going to use an angle debrider. And you will see that we can actually remove this segment of the uncinate also. So can you appreciate that is the natural os? See this posterior wall of the ostium, can you appreciate that? Okay, I am not injured, can you see that? That is intact. Okay, now at this horizontal segment of the uncinate, you will get a vessel, see this. Okay, this is one of the branches of the inferior turbinate. This is the uncinate process branch of the inferior turbinate branch, which is coming again from the pinopalatine. Actually, your blade is not sitting properly. So see, when I'm trying to suck tissue, are you getting any tissue into the debrider? You are not. So that means that uncinectomy is complete. Yeah, okay, you have not left much of uncinate behind. That is what it means. Okay. So if the disease is not much, then try to preserve this. Okay, but if you need to open it up, then do it from the inside. Okay, like this. And then you can actually take down this tissue. The suction is not good enough actually. Very good. After this step, we are just going to place one small Maracel here to reduce this kind of ooze. This oozing happens, like I said, when we do the uncinectomy on the other side also, I'll show you. Exactly at this horizontal part of the uncinate, you will have a vessel actually. So that usually will bleed, but it will stop. There is nothing to worry. It's not like it's a very big artery. Patient is not gonna die because of that vessel or anything. It's just that you need to control that ooze to make sure that you don't have any kind of blood-stained field. The more blood you have in field, the more light that it absorbs. So that is why your picture will start to look darker in color. Okay?
Dr. Medikheri, do you
Yes.
hear me? I have a question that making the enlargement of the ostium.
Yeah.
Medikheri ostium. What is the optimum diameter you will make it enlarged?
So that depends on the pathology that you're dealing with. If you're dealing with an inflammatory sinus disease where you want to have the widest ostium because that will allow more amount of saline and steroid to go in, then you should make as wide as possible. This is what I would say. From the nasolacrimal duct up to the posterior wall. So now if you observe, I'm just trying to put pressure on the lacrimal sac here, but we are not seeing any development. Okay, so that means we are still in the safe zone. Okay,
For enlargement, do you
anteriorly, yeah.
do you debride the whole of the surface opening?
The highest amount of mucociliary motility.
So we should avoid to debride the posterior margin.
If possible, yes. But if you are talking about a case like allergic fungal sinusitis, where the mucociliary movement is already gone, then there is no point. You might as well make a big opening because that will help you to allow more washing to be done.
But too large opening will produce an empty sinus syndrome.
Sorry?
Too large opening will make an empty sinus.
Not really. It doesn't matter. If we are talking about the nitric oxide theory that has already been disproven now by a meta-analysis, so that will not really change much for you. So if you are dealing with AFRS, then please go ahead and make a big opening because that will really help the patient to drain out all of that mucus on his own. The problem with AFRS patients is that they don't have good mucociliary.
You are out of view. Will you please look at pre-operative period to reduce the bleeding power?
What precaution do you take?
How do you combat the bleeding? Hemorrhage in surgery. What precautions do you take prior to the surgery, pre-operative period, and during the surgery also?
আপনার ভিতরে
So
ঢুকতে
prior
দেওয়া
to surgery, if you're seeing a lot of osteitis like we did on this scan, then I would not be in a hurry to do the surgery. I would probably be the patient like what they have done. So
How many days?
Ideally, this should be 3 weeks. Why 3 weeks?
Oral only or
Oral.
with local steroid spray?
Local steroid spray also can be given. There is no harm, but oral is a must because there will not be any penetration into the bone with a local steroid spray. That's not going to penetrate the bone.
What systemic steroid do you use?
We can use prednisolone. So why 3 weeks? Because the lifespan of a eosinophil is actually 3 weeks.
What is your dose?
So the dose, ideally it should be 0.5 mg per kg body weight at least. So if the patient
Single dose or
no, in divided doses, sir. So if the patient
because
is,
single or divided dose there is so many controversy.
So the problem with single dose will be that it will create a lot of gastritis for the patient. That is the only problem that we have, especially some patients might even develop an ulcer also. If you give this in a divided dose, it's always better. So for a 70 kilo person, you need about 35 milligrams of steroid per day. So what you can do is you can divide this into, we get 16 milligrams of prednisolone back in India, so we can do this as 16 mg twice a day to begin with for about a week. Then we taper it down to 16 mg once a day, and then we make it 8 mg once a day. That way we can taper this down and then we can give it to the patient.
So what about the wash with steroid? Will you please
At this point, before the surgery, washing with steroid is not going to really change anything because the sinus is already blocked off by the polyp, so it is not going to really push the steroid inside the nasal cavity. And we know that polyps don't have a very good blood supply. It is actually the underlying bone which has actually got a lot of blood supply. But the issue is that because the polyp is sitting on top and it is relatively avascular, it will not take up the steroid wash. So that is why we prefer to give oral steroid here. So that is pre-operatively. The other thing, not this one straight. The other thing that we can do is we can give the patient some tranexamic acid. So there is now evidence that if you give 500 mg of tranexamic acid per day for about a week before surgery, that will help you reduce intraoperative bleeding. You can also do this intraoperatively also. You can give about 1 gram of tranexamic acid during surgery. That will help to reduce the bleeding.
pre-operative for 7 days?
Pre-operatively for 7 days.
Thrice a day? 500
No,
milligrams?
once a day or twice a day should be good. The other thing that you can do intraoperatively is you can reduce the blood pressure and heart rate of the patient. Now, if you ask me which one of these two is actually more important, then it's the heart rate that is actually more important. Why is heart rate more important? Because if you look at the cardiac output is basically heart rate multiplied by stroke volume. Okay?
Blood pressure.
So if you reduce the heart rate, then the cardiac output will actually come down. But if the heart rate goes up,
98.
so how do you increase heart rate? One, if the patient is not gone deeper into anesthesia or is not relaxed or is not having enough pain management, then the heart rate will go up. The second thing is if you drop the blood pressure too much, then as a compensation, the patient's heart rate will go up.
What is your preferred blood pressure during the operation?
So if you're talking about hypotensive anesthesia, then there is no one fixed blood pressure for every patient. The definition of hypotensive anesthesia is that it should be 30% maximum by 30% less than the resting blood pressure of the patient. So if your patient's blood pressure, resting blood pressure itself is 200 by 110, then you cannot expect the anesthetist to take it down to 90 by 60. Am I right, sir? Anesthetist. So if you do that, what is going to happen is that there is going to be severe cerebral hypoperfusion because the patient's brain is used to a blood pressure of 200 by 110. So when the patient wakes up, he's going to wake up with a stroke. So that is the problem that you are going to have. So you cannot afford to do that to a patient, especially for a simple surgery like sinus surgery. You have to manage by other techniques. So the heart rate ideally, again it is 30% less than the resting heart rate. Then this has to be measured not once but 3 times. So you measure blood pressure and heart rate at 3 different occasions, and then we can assess whether what is going to be the ideal hypotensive anesthesia for this patient. So some of the common drugs that we use, at least in my OT, we use dexmedetomidine to sort of we put a patient on an infusion, and that gives us very good controlled bradycardia. Actually, the bradycardia is much better when compared to the hypotension there, and that is exactly what we want. We want a lower heart rate but a near normal blood pressure for these patients. Okay, so that actually helps us a lot. But the only issue with dexmedetomidine is that it's very expensive to be used as an infusion, but it gives us a very wonderful feel. The other thing that you can do intraoperatively is that you raise the head end of the patient's bed, operating table, by about 15 degrees. This is called as reverse Trendelenburg position. What this will do is it will actually cause venous pooling in the legs. That way, the venous return or the blood which is coming back to the heart, that is called as the preload. So if you reduce the preload, then automatically the cardiac output will actually come down. That way, capillary pressure will be less and mucosal bleed will actually come down.
So do you prefer GA in your maximum cases?
Absolutely, sir. So I don't do a surgery without GA. Reason being that we cannot do a very good complete job in these cases. Because most of the cases that I get are actually very complicated. So like in Bangladesh, a lot of people are doing sinus surgery now in India as well. So normally all these entry-level cases sort of get filtered out, and I usually get most of the complex cases only. So coming back to the surgery here, so you can see now after the uncinate has been removed, you can see the bulla ethmoidalis in its entirety. Okay. So bulla is actually the most constant ethmoidal air cell. It is not the most anterior ethmoidal air cell. The anterior most ethmoidal air cell is actually the agar nazi, which is sitting here. You can see this is agar nazi. This bulge which you are seeing is actually the agar nazi, and it is much more anterior to the bulla ethmoidalis. But this is the most constant air cell that we see. Agar nazi is a pneumatization of the anterethmoid into the lacrimal bone, like was explained on the CT scan lecture. So you may or may not see it. It's not always mandatory to see it. So what I'm doing is I'm going between the middle turbinate and the bulla ethmoidalis. I'm reaching the space which is hiatus semilunaris inferioris, and I'm fracturing it anteriorly. And what we need to do now is just remove these bone chips. So you remove this bone, and you should be able to open into the anterethmoidal group of cells. Okay, debrider please. So again we are switching back to the straight debrider. Observe that the blade is closed. And what I need to now identify, after I remove the bulla ethmoidalis, the next thing that I need to identify is my lateral limit, that is the lamina papyracea. So you can see here the bone, like I discussed with you, is very hard, so I am not able to remove it so easily. Can I have a straight through cut please? We are going to try to avoid using the drill as much as possible, because it's a little more difficult to spare mucosa when we use a drill. But push comes to shove, if we are not able to use any cold steel instruments to remove all of these partitions, then we will be forced to use a drill. So again see, I am now removing the floor of the bulla ethmoidalis. So I am only trying to tug on the bone. Try to leave as much soft tissue behind. Okay, can I get a straight punch please? Garrison's punch. So I am just going to try and define my lateral margin here. So the other thing that I forgot to tell you about giving oral steroids before surgery is that I don't wait for 3 weeks before surgery. What I do is I put the patient on 16 mg prednisolone twice a day, Predmet twice a day, and 1 week later I take the patient for surgery. Why do I do this? Because totally I need to give the patient 3 weeks of steroid, So after surgery also, during the healing process, when the patient, if the patient is on some steroid, then the healing is actually much faster and much better. So you have to understand that after 1 week, you have reduced the inflammatory burden significantly now, just with the surgery. So in the healing phase, the patient will be stepped down to 16 mg once a day for a week and then 8 mg once a day for a week. That will be good enough to reduce the remaining inflammatory burden.
গোল্লা কি বিশাল পিছনটা
In case of diabetic patient, how will you maintain the dose?
So in case of diabetic patients, we will, if the patient has very strong osteotic signs, then I will still put the patient on oral steroids, but we will ask the diabetologist to sort of manage the dose of their medication. So that way we can prevent a glucose spike when the patient is on steroids for a short time. And we would want to continue the same dose of medication probably for about 2 weeks after surgery also, because we are continuing steroids for 2 weeks after surgery. So this is 1 week before surgery and 2 weeks after surgery. The other advantage of doing this is that if you leave the patient with steroids for 3 weeks before your surgery, patient may not come back for surgery. Okay, they will think that okay, I'm a lot better now, so let me see, maybe next time when I really need surgery, I'll go. But it's just a matter of time before they again start having inflammatory sinus disease. And the other problem, at least in India, is that we get steroids over the counter. So the patient himself might decide to take steroids the next time. He may not even come to you. He might decide to take steroids on his own, and that might land him into other complications like Cushing's syndrome.
What you are using for the in the local? I mean, you are using with this Merocel to reduce the.
Yeah. So the I use plain adrenaline with the saline. So the dilution ratio is 1:10. So 1 ampule of adrenaline, if you are using, you have to use 10 cc saline. So here we are using 5 ampules adrenaline with 50 cc of saline. The advantage of using adrenaline is that because it's an intense vasoconstrictor, it works on both alpha 1 and alpha 2 receptors. That way, it reduces its own absorption. So you will not have a very big spike in the heart rate when you use adrenaline. So because it is causing vasoconstriction and because it is reducing its own absorption, so the chance of it causing a spike in heart rate because of absorption will be actually on the lower side.
Do you use steroid during the nasal douche in the postoperative period?
Yes.
What is the concentration? What drug do you use?
The only approved drug for now is actually budesonide.
Budesonide, that is the inhaler Cozicap or
Yes.
solution?
So what we use is actually, can I have an upfront punch?
budesonide propionide
No injection is available for the.
No, it is actually what we use for the inhaler itself that is used here. So the dose is available as 0.5 mg per ml. So you can use 2 resputes. So 1 milligram is what you want to use.
In each down sheet, half liter of saline.
Yeah. So I use normal saline only. I don't allow the patient to use water because they may not boil it correctly, and if they're using borewell water, then the bacteria will be thermostable because it comes from much deeper after It comes from much deeper from the earth's core, so they will not die when you heat the water up. So at least in the post-operative period, until there is mucosal healing, I would prefer for the patient to use actual normal saline. So we are still opening up the entire bulla here, as you can see. And like we rightly predicted on the scan, you can see that the amount of osteotic bone is actually quite significant. Can I have an angle plate, 40 plate, please? Upturn plate, please.
দাদাকে একটু এদিকে যেমন জিনিস শিখিয়ে আনিস তুমি একটু ওই পাশে পাশে
আমি তো দিছিলাম আমি খালি যাওয়া আসা করতেছি
স্যারের ফোন দিলে কি করবে
So it is important that you open up this wall, that is the bulla is actually overshadowing onto the maxillary osteo. You can see that here. Can you see?
Sir, how many days will you use the nasal douche? And how to prevent the recurrence?
So see, if the patient has got a temporary problem like a fungal ball, then it's going to be only until the mucosa heals. But this is a case of allergic rhinitis or allergic rhinosinusitis. So this is going to be for a lifetime. This has to be explained to the patient. Actually. It is similar to having diabetes. You have diabetes once, then you are not going to stop taking medicine. No? Because what are you doing? Like I said in the beginning itself, what are you achieving by doing surgery is only you are opening the sinuses to such an extent that there should not be any blockage for him to do the wash. The whole idea of doing surgery is to make him do the wash easily. Okay?
For this particular case, it looks like that it's an allergic rhinitis
Yeah, so he
case.
will recover for a lifetime. There is no doubt about the fact. So very few people, there is now some evidence with after this that some patients actually, can I have a wet cloth? Just wet this little bit here. So some patients now we have proof that their immune system sort of burns out after a couple of years. If it burns out, then they can stop douching. But we don't have sort of any markers as to who is going to burn out and who is going to continue to have inflammatory sinus disease. We don't have those markers to predict them right now. But we are working on it.
Thank you, sir. So, the point is, whenever any surgeon is claiming that if you do the surgery, things will be okay, will definitely backfire.
Yeah, absolutely. Because we see, I have seen surgeons who make claims that if you cut off the middle turbinate, you will have recurrence. I can show you hundreds of videos where middle turbinate is already cut off and there is thousands of polyps coming out of the nose. So that is not the correct way to counsel, or even for that matter, if you are ever demonstrating surgery, don't ever make the blunder of saying that if I remove middle turbinate, you will not have a recurrence. Okay, so that used to be a concept, very old concept, wash please, which is called as the ethmoturbinal concept, which was initially, it was a hypothesis which was given by David Kennedy, but later he himself actually accepted that it's a wrong hypothesis. But unfortunately, people who have read that paper long ago have not bothered to follow up and see that he has discredited that hypothesis now.
Exactly.
He himself has discredited it. So the problem here is that it is similar to having asthma. You have a genetic problem, okay, where you have inflammation, inherent inflammation in your sinuses. In the case of allergy, the trigger is from outside. Okay, so it is dust, fumes, smoke, pollen, dog hair, cat hair, animal dander, ragweed, all these things which can cause inflammation in the nose and the sinuses. So how does this disease progress? Initially, you will see the middle turbinate will be edematous. Why? Because maximum deposition or the highest air current or the eddy current is along the inferior surface of the middle turbinate. Correct? So that is the reason why you see inflammation along the middle turbinate first. In such cases, the sinuses will not yet be involved in the stage 1. As time goes by, what is next to the middle turbinate? It is the ethmoid. Okay, ethmoid and uncinate will start getting involved. So this is the second phase. So in second stage or stage 2, this is called as central compartment atopic disease or CCAD. Okay, in CCAD, the peripheral sinuses are not involved. That is, whatever sinuses are lateral to the lateral wall of nose or above this middle turbinate area will not be involved. That means maxillary, sphenoid and frontal will not be involved in CCAD. It's only ethmoid and middle turbinate and inferior turbinate which will be involved in central compartment atopic disease. Now if you leave the patient at this segment, this inflammation is going to keep on increasing to involve the sinuses. In that case, you go on to develop something called as eosinophilic chronic rhinosinusitis, wherein you have involvement of the middle turbinate, ethmoid, maxillary sinus, frontal sinus. Sphenoid usually gets involved in the end. Okay, it is not something which gets involved early on. If you have sphenoid sinus involvement in a case of allergic sinusitis, that means that the disease has been very much long standing.
Yeah.
Okay. So this is the way the disease progresses actually.
So patient counseling has ever been the key.
Absolutely. So see, the problem in my practice is that I see about 40 to 50 patients per day. In private practice, that is quite a number. I don't have the time to sit and explain everything to every patient. So what I have done is, I have got another person basically who does allergy and immunology work. she sits down with the patient, shows them videos, and she actually counsels them entirely.
And there is another option, sir, that you can load some videos on YouTube and say that you just see my videos and you can understand everything.
But the problem is that they may or may not see the video.
Yeah, that's it.
Okay, if you leave it to them, they will not do it. Especially in countries like India and Bangladesh, the patient is least bothered.
Yeah.
What they want to do is, they want to blame the doctor.
Yeah.
So what I do is, I make sure that somebody explains this to them and we take a signature also that this has been explained to them, and I also make sure that they write in that the patient will require lifelong douching, failing which the problem is going to come back. So this has to be taken in writing.
Yeah.
Give me a JQuery, straight JQuery. Here. So if you do that, then your chance of landing up with medical legal litigation will become very less. Can you see the quality of this bone? See, it's actually immature bone. Okay, mature bone will not have these pits here. Can you see?
Yeah.
So this is immature woven bone. This actually happens in two conditions. That is, one is it happens in inflammatory sinus disease like this. Actually, I am putting a lot of effort to break this bone. So this is very, very thick osteotic bone. The second condition that it happens in is inverted papilloma. Where does it happen? At the site of attachment of the inverted papilloma. Why? Because there is increased blood supply, so there will be increased amount of osteoblastic activity there. So these are the two areas where you will see very thick. And when I say inflammatory sinus disease, it could be anything from allergic, eosinophilic, AFRS, all these conditions you will see this bone. Okay. So now you have to break all of this bone step by step. Make sure in the meantime you attach, you manage to get some hemostasis. Don't be in a hurry to sort of, we can do this faster also, but you're going to have quite a lot of bleeding if you take. So try to control as much blood as possible in the field, especially since we are doing a demonstration. It's not that I want to show you that I'm really good at what I do, but I want you to see all the structures properly, that's all. So if you can see the structures well, then you will actually understand the concept a lot better. Rather than I can just, put my debrider in and debride everything and say that, okay, we are done with surgery, but it may not help you as much. So what, can I get a punch please? Yeah. So what you want to define here is, now I am trying to define. So the other thing is that you have to go wide before you go deep. Okay, don't be in a hurry to open this area. I want you to clear out all the cells here before you can actually go deep inside. Why? Because if you have a bleeder inside, then you will not have enough space to manage it. So just like in mastectomy, we say don't make a well. You want to have more space. You want to make it wider first. The outer table has to be drilled nicely before you can go inside. Same way here, you want to create as much space as possible before you go deep inside. So I think now we are close to the lamina. So how do we know we are close to lamina? One, the bone has gotten thinned out along the lamina. Second thing is I am going to do some ballotment. Can you see this? Can you see this? So I am balloting the eye, so I am now on the lamina. So that is my lateral limit of dissection. Why the bone usually, when you have extensive osteitis, why this bone gets thinned out, I'll tell you. The lamina will usually be thinned out in cases of extensive osteitis. One, because it's a very thin piece of bone. That is why it's called papiresia. Papiresia means like paper. Okay. The second thing is, such a thin bone, you cannot expect that it is going to have a good blood supply. So what happens, because of the inflammation adjacent to the bone, you will have osteoclastosis. That means it will take away bone. But because there is no new blood supply coming into the bone, there will not be osteoblastosis. That is, new bone formation usually does not happen along the lamina papiresia. Except the exception to this rule would be that if you have an inverted papilloma or a malignancy, where the tumor itself brings in a lot more blood supply, in such cases you can have increased bone deposition on the lamina. So since this is the lateral limit now I am actually going to go more posteriorly and superiorly also. So the first thing, like I said, after removing the bulla, see now we have removed bulla in its entirety. Can you see any remnant except here? Superiorly we have some small remnant, but otherwise along the lateral wall it is completely removed. The other thing that I want you to remember is, if you by mistake have opened into the orbit, that is if you have injured the periorbita, okay, then do not use a adrenaline pack. Why? Because if that adrenaline pack goes or adrenaline goes into the orbit, you can cause vasoconstriction of the retinal artery. In that case, the fundus actually will have very little blood supply. That can lead to blindness also. It has happened to some people as well. Okay, so be careful when you are using the adrenaline pack, especially if the periorbita is open. If lamina is open, that is not a problem, but periorbita should not be open. Can I get a Okay, so everybody is oriented now?
Right, oriented.
Yeah.
Dr. Gaurov, we are enjoying your surgery, at the same time you are speaking very nice way.
Thank you, sir.
Your scientific language is encouraging and enriching the knowledge of us and our students.
Thank you, sir.
Now, at this point, can you please say there is a rule of 6, 12 and 24, how to ascertain the position of the anterior ethmoid artery and posterior ethmoid artery at the optical canal position?
Yeah, so the rule of 6, 12, 24 is basically from the lacrimal crest is what we talked about. It's actually from here. So from the, this is more to do with the, the scan rather than on a live patient. So the anterior ethmoid artery will be 6 millimeters behind the
Anterior
crest, and the posterior ethmoid will be 12 millimeters, the anterior ethmoid will be 24 millimeters from the lacrimal crest.
No, it is 6.
The posterior, one second.
6, 12 and 24.
No, it's actually 24, 12, 6, I'll tell you. The anterior ethmoid is 24 millimeters posterior to the anterolacrimal crest. The posterior ethmoid is 12 millimeters posterior to the anterior ethmoid artery, and the optic nerve is 6 millimeters behind the posterior ethmoid artery. So that is how it goes.
Okay, thank you.
So now we are getting a glimpse of the agar nazi here. Can you see this? This is actually the agar nazi. How do we know it's the agar nazi? Because it is just behind the axilla of the, or just superior to the axilla of the middle turbinate. Okay. So now we know we have a medial limit. Medial limit is what? Middle turbinate. We have a lateral limit. Lateral limit is the lamina papyracea. Okay? So if you want to clear any tissue along the lamina, don't do this. If you do that, if you actually press along the lamina, you go into the orbit very quickly. So if you want to do a clearance along the lamina, let us say with the debrider, first thing is you ensure that you have good control of the debrider. So what I am doing is I am using an angled blade. Can you see this? Why I am using an angled blade? If I use a straight blade, I'll have to stick to the lamina. But when I am using an angled blade, I can stay away from it and just stay about a millimeter away. Allow the tissue to come into the debrider. Okay, don't do this. If you are going along doing this, then the chance of you entering into the orbit is going to be very high. In fact, PJ Verma did a study to identify how quickly the debrider can cause injury to the medial rectus muscle. It is actually a fraction of a second. It is less than 1 second is required for the debrider. Once it is intraorbital, less than 1 second is required for the debrider to actually cause injury.
এটা তো নিচে অনেক ওই মানে বললাম
স্কাল্পের যত তোমার সামনে দেখি পিছনে
So can we get a straight debrider now? I need some mirror please. So now where have we reached? We have reached the, what is this bone called? The second
gateway.
You can actually do one thing. You can squeeze out some salon from this. It's too much. Squeeze out some salon. Squeeze it out.
এক পাশ করতে তো 1 ঘন্টা লাগে গেল আর এক পাশে
We don't want more. We want less. Squeeze it, sister. Squeeze it.
সেভলন কেন দিবে
So this is actually the second lamella which we have. The first lamella what we had was actually the third lamella which we have. First lamella which we had was the uncinate process. Okay. Second lamella which we had was the bulla ethmodalis. Now we have the third lamella, that is the basal lamella or the true lamella. So what is the function of basal lamella? It actually separates the two group of cells, that is the anteroethmoidal group of cells, which are smaller and more in number compared to the posterior ethmoidal group of cells, which are lesser and larger in size. Okay. So how do you identify basal lamella intraoperatively? So basal lamella is actually part of the middle turbinate. So if you observe here, you can see, so the part of the middle turbinate which actually attaches to the lateral wall is called as the basal lamella. You can see this is actually continuous with the middle turbinate. So this is middle turbinate, agreed? And this is the part of middle turbinate which is attaching to the lateral wall. So this has to be the basal lamella. So why did I actually, if you observed, I wanted to remove this bulla overhanging into the ethmoidal infundibulum. Why I wanted to do that is, you want to identify the maxillary line, which is the highest point of the maxillary sinus. Okay, can you see that? That is the highest point of the maxillary sinus. So if you draw a line from there and you come medially, the point where it attaches to the middle turbinate is called as the maxillary line. Now if you enter the ground lamella or basal lamella at this segment, then your chance of injuring any critical structures becomes very less. So what I will do is, I will actually enter it at this point. This bone is very hard, so you have to be careful. And I have to fracture this bone laterally. So once you do that, you will enter into the posterior ethmoidal group of cells safely. So why we fear when we are entering is because you don't want to injure the skull base. So this looks like it could be the skull base, but once we open the sphenoid, we'll actually be more sure about it. So when you open this, right, you can experience that there will be a lot more bleeding than you had in the anteroethmoidal group of cells. So this is expected. Why? Because you are getting closer to the sphenopalatine artery. So the caliber of the vessel as you go posteriorly will be much larger than when you come anteriorly. The caliber of the vessel will become much smaller. So you are going to have a lot more bleeding as you go posteriorly. That is the reason why skull base surgery is so difficult. Because majority of the work happens behind the anteroethmoid, that is in the sphenoid or along the skull base is where majority of the work happens. Okay. So don't be afraid if you have a lot of bleeding. Just pack and wait for the bleeding to stop and then you can proceed again. So what is this structure that we are seeing? This is actually part of the superior turbinate. Okay. You can see this bone is also very much osteotic. Now it is not prudent to leave such osteotic bone, especially in the olfactory fossa, because this will cause anosmia for the patient. Okay. So you want to remove this inflammation. If you don't remove this inflammatory load, then what will happen is the patient will say that your sinuses will look all beautiful, but still the patient will say that I don't have a good sense of smell. So that is the reason why you don't want to leave this bone. If you want, you can leave the soft tissue behind, but this bone you don't want to leave it behind because it's extremely osteotic. Okay? So what am I trying to do? I'm actually just trying to grasp the bone alone. I don't want to injure the mucosa if I can help it. Let me try my best. Okay. So that was good. So we've removed that osteotic bone. So you can see that this part of the bone is also quite flimsy. There is a cell here. So this partition has to be opened up. This is called as a retromaxillary cell. Can you see that? This is behind the maxilla. So it's called as a retromaxillary cell. Straight legs please. So this horizontal partition we have to remove.
Okay, পিছনেই আপনার স্পনে করা যায় না রাইট আর না
মিডল টার্মিনেট যে লেভেল
So we are going to try to make as big of an opening as possible. Can I get an upturn through cut please?
কালকে তাকে বললাম যে পার্টিকেলটাকে ফ্র্যাকচার করা লাগে
So you can see here that there is a parting wall between the ethmoidal infundibulum and the
কিন্তু সে হলো
posterior ethmoidal group of cells. So this party wall I'm actually going to take it down. Okay, because if this party wall is there, then one, it will not allow the wash to go into the maxillary sinus. Second, if the wash goes in, it will not allow it to come out. The patient will feel some form of pressure in the maxillary sinus at all times. Okay, because it will keep stimulating the branches of the intraorbital nerve. So they will say, I have some pressure in my maxilla. That is what they might tell you. So is this the sphenoid sinus? No. What we are looking at? I think on the scan we had discussed which side is the sphenoid dominant. It's actually dominant on the other side. So here we may not find a sphenoid sinus actually. I don't think there is a sphenoid sinus on the left side. Yeah, so here we don't have a sphenoid sinus actually. So this is the end of the dissection as far as sphenoid is concerned, because this side we don't have a sphenoid sinus. It's only present on the right side. So that is something that you need to make note of. I've actually seen one of the surgeons, not in a demonstration, but when they were operating. So the patient did not have a sphenoid sinus and they kept poking into this space. And they landed up creating a carotid bleed. Okay, so you have to be very careful when you are reading your scan. If you are in doubt, it's better you leave that sphenoid sinus unopened rather than create a complication, because carotid bleed in a sinus case is not really acceptable. No court of law will be able to protect you. No lawyer can protect you. Because it is so, it is a very gross error to have. Especially if the CT scan is showing that there is no sphenoid sinus and you opened into that space trying to find the sphenoid sinus, that means you don't know how to read a scan. And that will be used against you by the defense lawyer. Sorry, by the offense lawyer. Spinopalatine artery, you will have to remove this mucosa. You will not be able to see it without removing that mucosa.
So এইটুকু অল্প একটু মিউকোজার সাথে লাগে আছে আর একটু ইয়া করলে তো ফল ডাউন করবে এইটা সুপিরিয়র টাইপের
So can you appreciate the fact that now the ethmoidal cavity is nicely opening up?
ও হ্যাঁ এই যে উপরে এটা
So this is a remnant of the superior turbinate. Can you appreciate?
ওই যে উপরে রয়েছে ওই মিউকোজাটা
This is the third or the final attachment of the middle turbinate to the lateral wall. So I have a question here: how to identify? If you want to do a spinopalatine artery ligation, where do we go? So this point of attachment that you see, if you come
attachment of the
middle turbinate, if you come anterior by about a centimeter or so, you can make a L-shaped incision here. You make an L-shaped incision like this, and you raise this mucosa. When you raise this, you will actually identify a projection of bone, which is called as the ethmoidal crest. That ethmoidal crest is the most consistent landmark for identifying the spinopalatine foramen. So if you remove the ethmoidal crest,
মিডল টার্মিনেট যেখানে লাস্ট আছে হ্যাঁ একদম ওই দেখা যাচ্ছে
তাহলে ওর ঠিক পিছনে লোয়েস্ট অ্যাটাচমেন্টের নাম হলো ক্রিস্টেট মেটালি আচ্ছা আচ্ছা ওর পিছনে থাকবে তাহলে স্পিনোপ্লাটিন এই যে ক্রিস্টটা ওপেন করে ফেলাইছে অলরেডি
So we want to sort of open up these cells.
মনে আর যাবে না ও গেলে
আর হবে না কখনো
Yeah, there is a lot of osteitis here. Not able to fracture this bone.
ওরে বাবা রে এটা হার্ড
So you are fighting.
অনেক পরিমাণে
I would try my best not to use a drill for an inflammatory sinus case, but push comes to shove and I'm not able to even remove this with a punch, then I won't have a lot of choice left. In that case, I will have to drill down this bone.
কম দামের কিছু নাই প্র্যাকটিস টেস্টিস করার জন্য
কি কম
এই যে এইগুলা
What do we need to identify now? The next landmark that we need to have, we have identified lamina here. Okay? We need to identify this skull base.
আগে শুরু করো শুরু না করলে তো ওই ল্যামিনেট পেপারে এসে তুলতেছে
Upturn punch, please.
হিসাবে দিয়ে দিল 6
We
24
are actually
20
now
12
exposing the pelvis. We are coming from behind forward. We are trying to remove the bone along the ethmoidal roof now. Roof of the ethmoid sinus.
তুমি আগে স্কেল বেজ আইডেন্টিফাই করতে হবে। এখানে স্কেল বেজ আইডেন্টিফাই না করে গোতাগুতি করা খুব রিস্কি।
কত দিবে যাচ্ছে কি আগেই আমাদের জন্য কঠিন হয়ে যাচ্ছে।
হ্যাঁ হচ্ছে কঠিন।
এই দেখেন কই গেছে ব্লাড তো ভি ভালো আসতেছে না।
আচ্ছা এই রুফে যে ডেটা চালাচ্ছে এর সামনে কিন্তু মানে অ্যান্টিবায়োটিক থাকার কথা
না, ট্রিটমেন্ট আরও অনেক রুফে এত কনফিডেন্টলি চালাচ্ছে কেন? কারণ ওখানে তোমার স্কাল বেজ অনেক শব্দ উৎসব, ওটা ভাঙতে গেলে হাতুড়ি দিয়ে ভাঙা লাগবে। তুমি সামান্য একটা গুতা দিয়ে ভাঙিয়ে দিতে পারবে না সেটা।
এটা কি পোস্টার এথময়েডালের ইয়া?
হ্যাঁ, তুমি যখনই এই মিডিল টাইপের এই বেজাল লেভেলে ক্রস করতেছো তখন স্কাল বেজ অনেক শক্ত। তুমি আর ওইটা ইয়ে দিয়ে ভাঙতে পারবে না যত ইনস্ট্রুমেন্টের গুতা লাগবে না কেন। এই জন্য তুমি এখানে ইনস্ট্রুমেন্ট এভাবে চালাইতে পারো।
পয়েন্ট
তো না দেখে ঢুকাই দিল ক্যারিসন ফার্স্ট।
হ্যাঁ আমি একটু আফসোস।
এগুলো হলো স্কাল বেস সেল, তবে এগুলো পোস্টার লিমিট ডিফাইন করে তারপরে আসা এন্টারলে আসা উচিত।
না ওইটাই যে উনি জানেই যে পোস্টার আমাদের ওখানে স্কাল বেস ঠিক যার জন্য ওরকম করেছে, কিন্তু সামনে তো করছে
ডেমনস্ট্রেশন।
এই আবার কে আবার কে রে ভাই
হ্যাঁ লোকজন ভাবে যে ওইটা হলো স্ট্যান্ডার্ড সাইন্স।
না 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 পোস্টারেট ম্যাডাম
এটা অনেক স্ট্যান্ডার্ড সাইন্স বলে এটা দেখায়। দেখি স্কেল কিছু নেই।
So we're just clearing all the cells along the
এইটা হলো
skull base.
পোস্টার লাগে আইসে তারপরে তুমি
পোস্টারের থেকে এন্টার ইন্ডিয়া বিগ
I'll just give me a wash.
দৌড়ান
ব্যাগ নিয়ে যাবেন
উপরে যাবি?
So one of the things that we need to understand is when we say chronic sinusitis with polyps, without polyps, right? When you say with polyps, we are not really doing much benefit by just classifying it as with polyps. Okay, so this is like saying patient has got fever for evaluation, okay, or pyrexia of unknown origin, because this could be dengue, it could be malaria, it could be anything, right? So when you say polyp, what is a polyp? It's a marker of inflammation, that's all. Okay, you can have polyps in allergy, you can have polyp in chronic sinusitis which is inflammatory, you can have it in allergic fungal sinusitis, even you can have it as a secondary problem in tumors. Right?
The bathroom is.
So you have to define what is the etiology of the polyp. Or a better example would be saying patient has vertigo. Are you happy with the diagnosis that patient has got vertigo? Don't you want to know if it's Meniere's disease, or if it is BPPV, or if it is central vertigo, or it is psychogenic vertigo, migraine associated vertigo? You want to know what the cause for this vertigo is, right? So here also you would want to know what is the cause for the patient's polyp. That polyp is just a representation of inflammation, that's about it. Okay? So you would want to classify this further. So you have to identify, that is why it is essential that you do a biopsy. If you do a biopsy, then you will get to know what is the predominant inflammatory burden there. If you identify the predominant inflammatory burden, then life is easier for you as well as for the patient, because then you know whether this patient has to wash for a lifetime, how frequently they should come. If it is allergy related, then it depends on whether the patient has got a perennial allergy or a seasonal allergy. If it's a seasonal allergy, then it could be something like pollen. If it's a perennial allergy problem, then usually what happens is it is usually dust mite or a pollen which is present throughout the year. After Blake's they are very close to the posterior. Can I get a drill, please? Because this is not going to come with punch or. So when you are drilling here, you have to be very careful because you see here the periorbital is exposed in this area. Okay, and I want to clear out this bone. I want to clear out this bone. Okay, and this whole segment of bone which is actually causing a sort of horizontal ridge. Okay, so we want to clear out all of this. So you have to be very careful not to go intra-orbital. Okay, so what we are going to do is, I don't have diamond here. Okay, let's just see, we'll just try and see this one. This is actually quite blunt.
এই ল্যামিনা পেপার এশিয়ার উপরে এরকম ফ্যাট গিলার মধ্যে একবার ধরাই গেলে দেখবি যে সব গেছে বাইরে।
You have to have a very firm hold of your divider.
অবশ্যই এক্সপার্ট
You
অনেক।
don't want this drill bit to jump. And if you observe, I am drilling only on the ridge. Okay? The only problem with using the burr is because it rotates at a higher speed, it is going to pull some of the mucosa off. But since the patient is going to be on steroid post-surgery, it is not such a big problem. This mucosa will come back. But if you leave all this bone, see, I am drilling it and still it is like not budging. If you leave all this inflammatory load or bone behind, patient is going to have definitely a lot more disease left behind than just clearing out some of the mucosa. Give me a divider now. Or give me an upturn super. Not 90, you don't have a 45 degree super. So I'm just going to go and try using a through cut here to sort of clear out all of this. We have, sort of broken down the bone with a drill. Any doubts in the audience? I'm happy to answer them while I'm operating. Hello?
No, it's fine, it's fine. I will request the juniors, if you have any question, please, come up.
Tamim, please, have any questions? Just ask him. এইবার মনে হয় ফন্টাল বের হয়ে গেছে।
The house is full. There is no one seat more for seat anymore audience. Okay.
Yeah, thank you.
So you'll be happy. everybody of our audience is enjoying your operation. But I have a question here.
Yes, sir. Yes, sir.
Can I ask you?
Yes, sir. Please, sir.
Actually, the practice is to do the sinus surgery.
Yeah.
Usually we do practice the frontal sinus first.
Yes, sir.
But
That is called as intact bulla technique.
Yeah. But did you practice it or not?
I did. Like, so for me,
But
this
in this case, you did not follow it, right?
No, I didn't. So the thing is, for me right now, I would want to identify the skull base before I go into the frontal sinus, because if I just trace the skull base backwards, then I will enter into the frontal sinus itself. There is nowhere else that I can go. So that is one thing. Second thing is, I have very little space to work with such heavy osteitis, and the lamina is actually eroded here. Can you see? So having these sort of issues, if I try to do an intact bulla technique, then the problem is going to be that I think the BP monitor is not working. Then the problem is going to be that I'm going to probably cause more amount of damage in the frontal recess than I can do good. So you can see there is a very small frontal sphenoid sinus osteum here. Let me just try to open that up straight through cut, please. Straight through cut. Straight through cut.
Actually, for our juniors who started right now to the FESS surgery earlier, okay? The beginner.
Yes, sir. Yes,
for beginner, as you're expert in FESS and skull base surgery,
yes, sir.
what is your advice them to only the intact bulla technique or what you are doing now?
So intact bulla technique, to me it makes sense if you are really worried about the anterethmoid artery, then yeah, intact bulla technique will make sense. But it is more about your comfort. Are you more comfortable with less space? If you are happy to do it with lesser amount of space, then yeah, intact bulla technique will work for you. I would like to have more space when I am actually operating in the frontal recess. So for me, to me, this is not that it's a generalized statement, but at least to me, when you're doing intact bulla technique, you are actually compromising a lot on the space that you have, and your instrumentability will be much less. And in this case, if you observe, this was not a good case for intact bulla. Why? Because the bulla was so prominent. Yeah?
Yeah, right.
The bulla was so prominent that it was coming into the ethmoidal infundibulum also.
Yeah.
In such a case, what are you going to achieve? You are actually just going to compromise your access to the frontal recess. And in that process, what will you do? You will create more cicatrization. Okay, so you are going to create more cicatrization in the frontal recess and create iatrogenic frontal sinusitis. So I would not do that rather.
Okay, thank you.
So there is a very rudimentary sphenoid on this side, almost as good as non-existent. You can see that. Okay, so that is a very small rudimentary sphenoid that we have. This one. This is actually the rudimentary sphenoid. You can see that. And this is an onode here. You can see the optic nerve shadow there. Yeah. So this is the rudimentary sphenoid. So let me just use a punch to open this up.
Which sphenoid is good for surgeon, rudimentary or huge pneumatization?
A big pneumatized sphenoid is something that I like because it makes my skull base surgery easy for me, especially if you are doing a pituitary case.
Okay.
If you have a small sphenoid, you will have to do more drilling.
More drilling, right?
Yeah.
It is a conservative.
Absolutely.
Yeah. So you need to drill more bone to reach the
Skull base.
Yeah. Okay.
I prefer a well pneumatized sphenoid. So now you have identified the skull base. Can you see that?
Yeah.
You have identified the skull base positively. Give me a straight through cut. So what am I going to do? I'm going to join this rudimentary sphenoid with this onode here. So I'm using a straight through cut, and I'm going to make this onode itself as the new sphenoid. Okay? Because you don't want any mucostasis to happen in that sphenoid. That sphenoid is of no use to have such a small sphenoid It's not going to benefit anyone. So might as well open this party ball and make this into one sinus. See that?
Only and spinal.
Absolutely.
Yeah,
See that?
yeah.
See that?
Okay.
Okay, so just make it into one sinus, because if there is mucus which is collecting here, that will create more problem for you. Can I have a drill, please? Create drill. Drill.
সর্বনাশে
Whatever you give, I'll
সব জায়গাতেও ডিল
So because see, there is a partition here. Can you see this partition? This is not a this thing, septum, incomplete septa or anything. This is actually a proper partition. And if you see the scan, you will see that there is hardly a sphenoid sinus on this side. There is barely a sphenoid sinus on this side. Opposite side has got all the sphenoid actually. So that is the reason why this is actually an ONOD cell here. And if you see, the pneumatization is posterior-superior. This sphenoid is ending here, but ONOD is going much behind the sphenoid. Can you see? And what is the position? This is posterior-superior, this is antero-inferior. So this has to be sphenoid, this has to be ONOD. Okay? So what am I going to do now? I'm going to drill this inferior wall. Okay? To sort of make a nice wide extension. Okay, take a rider, please. So this is good because, see, I would want to rather show you a more challenging case than show you something which is, what we call as lollipop cases. Lollipop cases will not do any good for anyone. The more challenging case that I demonstrate to you, the better understanding that you will have how to handle complex cases, right? Because what happens is, when the demonstrator demonstrates here, everything looks very nice and hunky-dory because because of the choice of the case. You choose an easy case and you demonstrate, and then everybody feels like, okay, I can do this, and go back and try to do it. And then they realize that, oh God, this is like, there is so much bleeding happening in this case. So I would rather show you a case which is, tough, and how to manage it.
Actually, sir, you are doing fantastic surgery, okay? Every one of us enjoying your surgery. It's a very difficult case and you make it easy. So easy.
Actually, it is easy. I am not making it easy. The thing is, people have made it difficult. Let us put it that way.
Yes.
Punch, please. So there has been so much fear which has been created around sinus surgery that most people are very scared to take it up. But at the same time, I want to say that, as a beginner, you should know some amount of your limitation.
Yeah.
I am not trying to dissuade anyone from doing sinus surgery, but I have had a experience just 2 weeks back where one of the youngsters actually has completely eaten away the medial rectus muscle of one of the patients. So if you are not very well versed with your anatomy, again, see, surgery without reading is definitely not going to work for you. The first step to anything is you need to read. If you are going to be able to read well, only then you will be able to know where I am. And mind you, I want to point out that navigation cannot be an excuse for your lack of anatomical knowledge. If you think that I have navigation and that I'm going to use navigation and manage, and I don't want to read, even though you keep the navigation probe, you are not going to know where you are. So how can you interpret where you are? So at least to know that, you should have a very good anatomical knowledge. There is absolutely no excuse for not having anatomical knowledge. Now there is one very nice thing that I want to show you here. Okay, what I want you to appreciate is, if you observe the kind of bone that we were taking out, the superior turbinate, the the cells and everything. Did you observe? I showed you. It's very immature woven bone. Correct? See this bone. See this bone. This is not healthy looking bone. But at the same time, I want you to appreciate this bone. See, this is very healthy looking bone. You understand?
Yes, sir.
So this will not cause any problem. This bone will not give you any trouble at all because there is no inflammation in that bone. But you look at this bone. It is so uneven, jagged. This is all neoestrogen, immature bone. This bone, you try not to leave it if you can. If you don't have a drill, you don't have a choice. But if you have a drill, then you would rather use that. Because if you think that, okay, I'm going to focus more on mucosal preservation and you leave this osteotic bone, see, mucosa will respond to even nasal douching with steroid. But this bone will not respond to nasal douching. Okay, you will have to put the patient on prolonged oral steroids to get a good result there. So, you would rather drill out all this unhealthy bone and leave the patient with healthy bone. Can you imagine such thick bone along the lamina? So where we are working is on the lamina only right now. So now can you see this is healthy bone? Agreed? This is much healthier than what we were seeing back there. So don't try to replicate what I am doing. Okay, I'm actually very close to the periorbita here. Yeah, no pressure, absolutely. So it's important if you're drilling along the lamina, don't put any kind of pressure on the drill. Yeah. So see, there is not a single partition on the lamina now. Can you appreciate that? All the way up to the neosphenoid. I would like that drill still. Except for there is a ridge of bone here. So this ridge of bone, what is the problem? Is that it will create a pocket behind it. See that? So I would rather want to remove this ridge of bone.
Do you think that this ridge of bone lies over the carotid canal?
By the vertical?
Carotid artery.
No. Carotid will come in behind the sphenoid wall. I am in front of the sphenoid. So this is actually part of the pterygoid process. One second. So just to clarify, see, you can see this is the optic nerve there. Can you see this opticokerotic recess here? See, it is not a very prominent OCR, but can you see this?
Right.
This is called as the medial OCR. Okay?
Right.
So the opticokerotic recess, below that will be this blue shadow. Can you see this blue shadow here? That is the cavernous segment of the carotid. Okay, I am drilling here. Can you see this bone which was here? I am far away, about a centimeter away from the carotid. Okay?
Right.
So this is good enough. Now it is open to the nasal cavity, this area. Give me a Marasol sponge, please. So now we have identified that is the skull base above there. So there is a ridge of bone here which needs to be smoothened out, right? So I'm going to place this sponge here to reduce this bleeding in the sphenoid. We have the second OT also. No? We have access to second OT. Okay. I was thinking that when I'm demonstrating the second side, we should probably start with the expo. So we can save time and we can keep this as picture in picture. I will answer the questions from here. Yeah, that will be easier to save time. No? Okay? Agreed?
So what's the document?
Okay, I'll manage both those. Let's not waste people's time. What we want to do is we want to give them maximum knowledge in these 2 days. Instead of only me, let everybody get a chance to. Give me the chance, please. You can, but what I usually like is that Mucosa is looking very nice. But I don't want to damage the Mucosa if I can help it. With the drill, because it rotates, it usually will pull some of the Mucosa. Like if you see here, see, it will pull some of the Mucosa. You can't really help it. But if you can avoid using the
But this mucosa is very healthy. It is very much required to remove this foamy hair.
yeah. So without damaging the mucosa, if you can remove and make a smooth wall, you want this whole space to be like a waterfall. It should just, the frontal should just drain like a waterfall all the way back. You don't want to leave any partition. What happens if you leave partitions is that mucosalization will not happen sooner. If it's a flatter surface, it's easy for the mucosa to grow over and above it. After through. Okay. So now what I am doing, I'll switch over to a 70-degree scope. We'll try to open into the frontal recess. So everybody is happy with the detection so far?
Oh,
Any
fine,
doubts?
fine. Thank you.
Any doubts? Now we are going to the frontal sinus. So what I want you to appreciate is the fact that see now we have so much space to work with angled instruments. Can you see that?
Sure.
I'll show you where the agar starts and how much space you would have genuinely had if the bulla was still intact. This was a very prominent bulla. This was not a good case actually to do.
Intact bulla.
Yeah, it was not a good case because if the bulla is so prominent, you're going to end up compromising your access. And the number one rule in any surgery in ENT is access has to be very good. So can you appreciate now? I'm using a 70-degree scope. I'm rotating it. You are looking into the maxillary sinus. Can I get a backbiter? So this would be a good opportunity for you to actually fine-tune your maxillary sinus surgery. You can see there are a few bone chips sitting there. So what I would want to do is just remove those bone chips. Okay. So now you can see that is the intraorbital nerve shadow. Can you see that?
Right, sir.
Yeah. So I've got a question saying how to handle the 70-degree scope. So there are two ways of doing it. So if you're working in the frontal sinus, if you're not very comfortable, this is the technique I would advise. So identify, you come in looking upwards. Identify the middle turbinate and the axilla and go into this. So when you're going here, with my left hand, can you see on the external camera what I'm doing?
Yeah.
Yeah, so you can see now that is I'm at the junction of the middle turbinate. So when I come here, I slightly rotate the scope, go in and then rotate back. If you go straight, you are actually soiling your scope. Can you see?
Right.
You will soil the scope. So what you do, either there are two maneuvers which you can do. One is you will have to go lateral and then go like this. Okay, that is one maneuver. Other one maneuver is you just tilt the scope like this and then come back. Now if you want to work in the maxilla, you can just tilt the scope at 90 degrees and you'll be able to look inside the maxillary sinus.
Right.
If you want to go straight, looking like this only, rather than look up and go, identify the inferior turbinate. See, this is the inferior turbinate. Come above the inferior turbinate and then just go along the inferior turbinate roof. and you will reach the maxillary sinus. So these are the two ways you can work here. Okay. So now, can I have an upturned leg sleeve, please? So now we have identified this is the axilla of the middle turbinate. Can you upturn please? Here, it's here. It's here. It's here. Okay, so you have identified the axilla of the middle turbinate. Correct?
Correct.
So now the cell which we were seeing here, this bulge, what I was telling you is called as the agar nasi, correct?
Correct.
So give me a J Kiran. Now what is the boundary of the frontal recess? Straight will be better. Okay, it's okay, I'll use this. So the boundary of frontal recess is actually the posterior wall of the agar. Yeah, so this is where the bulla was attached actually. You see, we still have a little bit of attachment left here. Can you see?
Right.
Yeah. So this is how much space I would have. If I would have done intact bulla, I would have had to work within this much space. Now I have space all the way here, so I have space for annual instrument. Imagine this bulla was coming from here and it is attaching here. Can you see this remnant here?
Yes.
So I would have had like only this much space to work. Is it really worth it? Is the question that you have to ask yourself. If you are happy working within that space, absolutely it's your call. Nobody is going to judge you or nobody is going to judge me also. Ultimately the goal has to be only one thing, that you have to open the frontal sinus properly without causing curved suction, please. Without causing any injury in the frontal recess. If you can open the frontal sinus, then fantastic. Go ahead and open. Whether it is intact bulla or not intact bulla, nobody will ask you once the frontal is open. Correct? So now what we need to do, we have identified this is the anterior most ethmoidal hair cell. This is actually the agar nazi. Okay? You can see this is the agar nazi cell because I can identify a roof here. But there is a communication between agar nazi and the frontal also. Can you see that?
Yes.
So there is two ways of doing this. Let me just take a look at the scan. The frontal sinus on this side is, it is a little narrow. Okay. So give me a J curate or a curved punch. So there are two ways of doing this. When you are opening into the frontal recess, one, either you can come from behind forward, wherein you just punch out all this bone. That is nothing but the posterior wall of the agar nazi. And you can see this bone is not looking healthy again. Can you appreciate it?
Yes.
Serious? It's got like this ragged edges. Yeah. Yeah. You can see, appreciate that this is all osteotic bone. That is why there is so much polypoid inflammation that is happening here. And when you are doing any punching of a horizontal, ridge of bone in this area, do it along the middle turbinate first. Why along the middle turbinate? Just in case, if the anterior ethmoid is in a mesentery here, then you want it to bleed inside the nasal cavity here. You don't want to remove this bone and it retract into the orbit. Correct?
Correct.
So you want to see this was the agar. I just want to show you the anatomy very beautifully. I can show you now. So I told you that the boundary of the frontal recess is posterior wall of the agar, anterior wall of bulla. See, this is anterior wall of bulla. This is posterior wall of agar. In between that, if you go, you will reach the frontal sinus. Can you appreciate that?
Yes, you can.
Yeah. So can I have a curved debrider here? So what I need to do now is I'm going to remove all of this bone. Sorry, all of the mucosa and take you straight inside the frontal. So you can appreciate here there is some bone that is actually there is some bone that is actually very osteotic. And where up to what limit should you take this opening? So you can see very nicely this is the skull base here. This is the lamina. This is the middle turbinate. So I have to remove this ridge of bone here. It's blocked, I think. So can you see that is the frontal sinus?
Yes.
This is the agar. See, there are two separate cells. See this?
Right, it is.
Okay, J, please.
Nicely sit.
So what happens is when it comes to frontal, nobody will usually take the time to identify these landmarks nicely. They just start poking around and then they create either a CSF leak or excessive bleeding. You know, these are the problems. If you identify the anatomy so clearly, then there will not be any confusion, and this you have to do from the first day of your sinus surgery. Don't think that when I become an expert I'll do this. To become an expert you have to do this. If you really love what you do, then you'll actually enjoy the process more than the end result. Okay? So see, now again I am actually opening the horizontal ridge. So where should my opening be? It should be along the middle turbinate, not along the lateral wall. J curate once more. So what I would want to do is, I want to check if I can extend this opening still more anterior. Okay, I am just checking what is the bone. Okay, how hard is the bone? So you want to remove this agar completely and try and make it into one opening. Absolutely, I completely agree with you that it is a little difficult to do instrumentation with an angled scope and an angled debrider, but that is something that comes with practice. So the other good thing that we have when we use an M4 is, can you see I am rotating the blade of the tip of the blade, can you see that?
Right, you can see. It's very, very important to keep the
Blade in view,
blade
yeah.
side.
So see this?
Control.
Now if I want to remove tissue along the posterior wall, I can always do that here by looking at the cutting edge of the blade.
Turn the cutting edge.
So, can I have a drill please? You can see that on the lamina here, there is still a little bit of osteotic bone. Can you see that?
Right, you can see.
Yeah, I mean the frontal sinus is open.
Yes.
Okay, there is no doubt about it. Frontal sinus is open, but what will happen now is, if this osteotic bone is left behind, this osteotic bone, can you appreciate this?
Yes.
Irregular jagged bone, if it is left behind, yeah, this we will remove. Let me just drill this out, or you can give me the debrider if it's already there, or drill it in, okay, no problem. So what is the landmark for anterior ethmoid? It is usually one cell below the frontal. So this is frontal sinus, this is the rudimentary supraorbital cell, and this is the anterior ethmoid artery here. See this?
Yes.
Okay, so this is the anterior ethmoid artery. Okay. So let me just try if I can drill out. The opening is very narrow. Can I have a diamond drill? I don't want to use a cutting board here because the space is very, very narrow. A small diamond will be nice. Yeah, give me that one. So normally what I use is, I use a stylus handpiece with a transnasal burr because the shaft is very thin and narrow. Okay, but here we don't have a matching handpiece for the drill that we have. So we're using this debrider blade, debrider bar. We'll do with whatever we have. Try to be as safe as possible. Drill out all of this bone. We sort of create a nice wide opening. Yeah, the important structure is the orbit. So here you can enter into the orbital pad very fast. So the stroke should not be like this. It should be longitudinal. Okay, you don't want to drill at one point very long because then you will dip into the orbit. Give me a wash please. Can you switch that to a debrider, an angle debrider, 90 degree or 60 degree debrider? It would be 90. Dr. Martin has not come today.
Tomorrow he will come inshallah.
Okay, okay. I'm so used to having him ask all the questions. So he has a very dynamic personality. Different. I'm done. This is the last bit. Once we remove the polyp, this red test is over.
But what would you do if the whole frontal sinus would be blocked with the or filled up with the polyp?
Sorry, sir?
What would you do when the whole frontal sinus will be filled up with polyp?
We still go in and debride. There is no problem with that.
But the lateral margins cannot be seen by your scope.
Yeah, so if that is the case, see, the polyp is not the problem, right? The problem is the fact that the sinus is not open. You just open the sinus and put the patient on oral steroid if you feel that it's not safe. The other option is if you want to do, like let us say, for polyp I would not do this, but let us say there is a CSF leak far lateral in the posterior table. Then you can do something called as an orbital transposition. Okay, can you see that? That is the frontal sinus. How do I know? There is a concavity there, convexity along the posterior table. Can you appreciate?
Right, we can appreciate.
Yeah, and see the bone. The color of the bone is yellow. Whereas if you see the bone here, it is more whitish. So that tells you that it is dense bone. So that dense bone is nothing but that is the frontal sinus. So you can see the whole skull base like a waterfall. It is draining down. That is the maxillary sinus that is nicely open. All the way up to the roof we have opened. All the way up to the posterior wall we have opened. That is the inferior turbinate. Up to the nasolacrimal duct. Just give me a straight blade speed. And posteriorly our limit would be the skull base and the sphenoid sinus. Suction please. And see, we have preserved as much mucosa as possible. And we have not left any of that inflammatory, dirty looking bone. Have you just observed? We have not left any unhealthy looking bone anywhere. Okay?
Okay, it's an excellent job done.
Yeah. So this is what we want to have as an end result. So I can even rotate this 70 scope. There is a small piece of medicine here. Straight plate speed please. So I can use this like a 0 actually. And I'm going to remove this medicine. So if you really want to get good at sinus surgery, start using the 70 scope more and more often. See, this is a rudimentary sphenoid. Can you appreciate?
Right, we can
There is barely anything there. If I had a straight transnasal burr, I would have drilled this even more. The problem is that burr is a little thick. I will end up damaging a lot more mucosa than doing good. But this is a rudimentary sphenoid, so I'm not going to really touch it. That blue shadow, what you're seeing there, that is the carotid. Okay. Can you appreciate?
Yes.
That is the carotid, and that is the optic.